behalf of the entire team Panacea, I very warmly welcome you, sir, and extending greetings and warm personal regards to Dr. Rajiv on this forum. Thank you so much for giving us this opportunity of welcoming you all here. On behalf of entire team Panacea, I just wanted to wish you all a very happy Onam also. It's a great day today. And my vote of compliment will go to Dr. B Agarwal for arranging such a wonderful session on hemostasis and thrombosis, case-based discussion. To all the panelists also, I am welcoming you all. With this, sir, I just want to hand over the session to you. Over to you, sir.
Thank you, Mr. Shailendra Kumar, for supporting us. I'll just share my screen. So good evening to one and all. Our guest speaker this evening is Dr. Rajiv Pruthi from Mayo Clinic, US. He'll be speaking to us on hemostasis and thrombosis, a case-based discussion. This webinar is brought to you by Mumbai Hematology Group, supported by Panacea Biotec, and managed by Mice Ideas. I thank Mr. Shailendra Kumar Srivastava and the team Panacea Biotech, Mr. Rajesh,
recording in progress,
Mr. Kalpesh and the team Mice Ideas, Executive Committee of Mumbai Hematology Group, our guest speaker, Dr. Rajiv Pruthi from Mayo Clinic, all our discussants who are themselves eminent hematologists, and you participants for sparing your Saturday evening. The discussants today include Dr. Chandrakala S. She is Professor and Head, Department of Clinical Hematology at KEM Hospital, Parel, Mumbai. Dr. Mukul Agarwal, he is Assistant Professor, Department of Hematology, All India Institute of Medical Sciences, New Delhi. Dr. Aditi Jain, Assistant Professor, Vardhaman Mahavir Medical College and Safdarjung Hospital, VMMC, SJH, New Delhi. Dr. Ankita Sen, DM Hematology, Hematologist and Hemato-Oncologist, Emory Hospital, Salt Lake, Kolkata. Dr. Ruchi Khanna, MD Pathology, Associate Professor, Department of Pathology, Kasturba Medical College, Manipal. Dr. Tejaswini Gudubande, DNB Hematology from Majumdar Shah Medical Center, Narayan Health, Bangalore. With this, it's my pleasure to introduce our guest speaker, Dr. Rajiv Pruthi, formally. He has been our regular visiting professor at number of occasions in the last 20 years to Mumbai Hematology Group, Indian Society of Hematology, and of course, he had educated us in hemostasis and thrombosis at multiple occasions. He is Associate Professor, Mayo Medical School, Rochester. He is Consultant, Department of Internal Medicine, Hematology, Department of Lab Medicine and Pathology. He is Director of the Comprehensive Hemophilia Center and Co-Director, Special Coagulation Molecular Hematopathology Labs. He was born in Nairobi, Kenya. He did his medical schooling from India. Subsequently, he did residency in internal medicine in Milwaukee, followed by fellowship in hematology, oncology, molecular biology, and genetics research at Mayo Clinic, Rochester. His clinical and research interests include lab diagnosis and management of bleeding and thrombotic disorders. With these few words, I invite him to deliver his lecture on hemostasis and thrombosis, a case-based discussion. Over to you, sir.
Thank you very much for the kind introduction, Dr. Agarwal, and for the invitation to present to such an illustrious group. It's an honor to be among such a very experienced individuals. And it's actually particularly an honor to have Dr. Ruchi Khanna on the panel, because actually I did go to medical school in Kasturba Medical College in Manipal. So thank you very much for the introduction. And without much further ado, I'll go ahead and start my presentation. I hope everyone can hear me. It's very clear.
Yes.
So over the years, I realized that, it's good to have evidence-based medicine for everything, but that's a utopia or nirvana that we will probably never achieve. So very early on when I started my career in hemostasis thrombosis, I thought the best way to teach coagulation disorders is to use cases. In my experience, the moment somebody puts up the coagulation cascade, the whole audience falls asleep. So case-based discussion is very useful, and a lot of judgment goes into how you approach these situations. So at the end of this talk, I hope to be able to highlight the importance of clinical correlation between the patient's presentation and results of coagulation lab testing. So using a case-based approach, we will cover some common causes of artifactual results of coagulation testing, and then talk about lab correlates of selected inherited and acquired bleeding disorders, and then how best to pursue a prolonged and abnormally prolonged PT and APTT. The way I approach it and the way I teach the residents, the fellows, and even other faculty is the differential diagnosis of a prolonged PT-APTT is really as easy as A, B, C, D. Think about it as A is for artifact. Now I cheated a little bit here. The B I couldn't figure out any other way to start something with a B, so I put inhibitor in here. The C is coagulation factor abnormalities. And never forget drugs. Physicians are very good at prescribing medications, and a lot of the times the anticoagulants themselves can cause complications. So if you take a step back and look at hemostasis, you can broadly categorize it into a primary and a secondary hemostatic response. The primary hemostatic response occurs when you injure your vascular endothelium. There's an initial vascular vasoconstriction, and then platelets and von Willebrand factor interact with the subendothelial tissue to form a primary hemostatic platelet plug. However, this platelet plug is not in of itself sufficient to maintain hemostasis, and therefore you need the coagulation system to kick in, form your fibrin clot, and stabilize that hemostatic plug. That's known as a secondary hemostatic response. Now, this doesn't mean that things are happening in sequence. This is all happening concordantly at the same time to stop the hemorrhage. The PT and APTT test that we so commonly use really only assesses your procoagulant system. In other words, your clotting factor cascade. So I will launch off into my first case here of a 47-year-old male who was born with a complex cyanotic congenital heart disease. He had a single ventricle. He had some transposition of the great vessels, and he also had known severe pulmonary hypertension. So as a child, of course, he had undergone corrective surgical procedures. And the good news is patients are living much longer. Now, here he is at 47 years of age. With his prior surgery, there was no excess hemorrhage, and there was no family history of bleeding either. So he came for a follow-up. The cardiologist wanted to do an angiogram. This is the patient's hemoglobin and hematocrit. So not a surprise, he has a cyanotic congenital heart disease, very high hematocrit. The cardiologist ordered a prothrombin time and an APTT. The reference ranges are in parentheses, and these were his results. So now, of course, you're left with the question, what do you do next? Essentially, what you have to do in this situation is reduce the amount of citrate that's in the collection tubes, and lo and behold, results were normal. So I will explain what the mechanism of what's happening here. So here's the complicated coagulation cascade with the extrinsic, intrinsic pathway that converge on a final common pathway. And the point of showing this is that if you look at the individual reactions, calcium is very important in activating clotting factors. So calcium phospholipid coagulation factors sit on a phospholipid surface, and they activate the clotting factor. This leads to fibrin formation, thrombin generation, fibrin formation, and your cross-linked fibrin clot. So the point here is calcium is an important cofactor for coagulation reactions. When you are doing a PT and APTT, you're taking the patient's plasma in a collection tube that contains citrate, and it comes in a fixed amount of citrate. So when you get that sample to the laboratory, you have to, the citrate, what it does is chelates calcium, and therefore it acts as an anticoagulant. So you have, and that's important because you have to transport that specimen to the laboratory. So you don't want that specimen to clot on the way to the lab. Once you get to the lab, for the APTT, you're adding a contact activator and a fixed amount of calcium and phospholipid. For the prothrombin time, you're adding tissue factor, a fixed amount of calcium and phospholipid. That activates the cascade, and time to clot formation is your PT or APTT. And we're going to emphasize on the calcium here. As I mentioned, the collection tubes come in with a fixed amount of citrate that is supposed to result in a final ratio of citrate to plasma that's 1:5 in a patient with a normal hematocrit. Now, when you have someone with a high hematocrit, there's a relative smaller amount of plasma that's collected, and therefore the anticoagulant that's pre-filled in the collection tube is in relative excess. So that's a problem, and therefore the amount of the fixed calcium that's being added back is not enough to result in a clotting cascade, and therefore the clotting times are prolonged. So you have to be aware that the patient has a high hematocrit. You actually have to get a fresh tube and then add the right amount of citrate back into the tube. And there's a nomogram that's available for this. There's no magic, there's no science here. I mean, there is science, but you don't have to memorize it. There's a chart that you can follow. Key thing is clinicians, all you can do is let the lab know patient has a high hematocrit, and it's really the lab's responsibility to adjust the citrate. Here's another case of I direct the special coag lab here, and we have a large reference lab practice. What that means is we get samples from all over the world and the country, but we don't always get the clinical information. So we're left sometimes either trying to reach the ordering provider or physician, or trying to do a lot of lab tests to figure out what is wrong with this sample. So this was a sample that was submitted to us for a lupus anticoagulant profile. So we have different profiles in our lab. So bleeding profile, lupus anticoagulant, thrombophilia, and then we do the right tests and we do an algorithmic approach. So here were the patient's data. Again, no clinical information. Prothrombin time was prolonged, and when we mixed it, it was inhibited. So inhibited PT, and the APTT was also inhibited. So we had either a final common pathway inhibitor, or we didn't know what was going on here. But again, this was a lupus anticoagulant sample. So we go ahead and do the additional tests, the platelet neutralization procedure. Sorry, this is shifted to the right. In this test, to the patient's APTT, we're adding in platelets as a source of phospholipid. And actually, it's supposed to shorten if this is a lupus anticoagulant, but it doesn't. So it doesn't quite fit. The second test we do for lupus anticoagulant is the dilute Russell Viper venom time. There's a screen, a mix with normal plasma, and a confirm, which is a phospholipid step. So the reference range here is 1.2 or less. So we could see a prolonged screen, but really not a mix or a confirm. So the pattern didn't quite fit. What happens here is when we see abnormalities in any of the screening tests, then we automatically do a thrombin time to make sure there's no anticoagulant in the specimen. So the thrombin time here is prolonged. I apologize, I didn't provide the reference range. And then we also do a replase time to make sure there's no dysfibrinogenemia. In this sample, the thrombin time and the replase time were prolonged. So this was quite a mystery. Now, we were trying to get a hold of the ordering provider to see what's going on with the patient. In the meantime, I went back to the tube, the original specimen tube that was sent to us. Here is the specimen tube. The label contains all the tests that were requested. And then we peel back the label. And lo and behold, the sample should have been collected in citrate, but it was actually collected in EDTA. Now, EDTA is a much more potent chelator than citrate is. And so you're going to get some bizarre abnormal results. And that was the case in this sample. So it's a pre-analytical variable. And the challenge with our reference lab practice is we just receive a frozen specimen with a label that the local lab puts on, and we can't always tell that whether it's citrate or EDTA. In this instance, in this previous case, the lab that ordered the test actually did provide us with the information. It was handwritten on the tube, so we were able to solve that. So as I mentioned, the EDTA is a much more potent chelating agent. and it reduces the availability of calcium in the assay, and therefore you get abnormal results. So what does the EDTA do? It prolongs your clotting times. It falsely reduces your clotting factor activities, protein C and S, and you can actually get a falsely positive or a false abnormal activated protein C resistance assay. And more importantly, if you're trying to diagnose TTP in a patient and you send a sample for ADAMTS13 testing, it should be collected in citrate. But if it's collected in EDTA, you're going to get a false reduction in ADAMTS13, and therefore you will misdiagnose the patient as having TTP. So to summarize, artifactual causations for prolonged clotting times: high hematocrit, EDTA anticoagulant. There certainly could be anticoagulants in the specimen. Quite often, if a sample is collected through a central venous catheter or an arterial line that's coated with heparin, that can result in a marked prolongation of the clotting times. Or if a patient is on a direct thrombin inhibitor and the samples collected for coagulation testing, you can get abnormal results. And then clotted specimens, so if the samples collected and before processing somehow a clot forms, that can consume the clotting factors and falsely lower levels. At what hematocrit cutoff should the laboratory start adjusting the citrate? In general, 55% or higher hematocrit is felt to be the cutoff above which the citrate should be adjusted. This is an example of a female who had a PT and an APTT collected, and the lab system is not perfect. It doesn't quite capture what the source of collection was, whether it was central venous catheter or peripheral blood. And when we repeated it on a peripheral blood, the APTT was actually normal. And then we went back and looked at the chest texture of the patient. Now, we didn't have the patient, I didn't see the patient myself, but this is a central venous catheter. It's a portacath. So the patient had this for chronic administration of antibiotics. And the sample was collected and it was contaminated with heparin. How do we detect heparin? As mentioned, we do the thrombin time test in the laboratory. And if it's prolonged, it could mean an anticoagulant, or it could mean a fibrinogen abnormality, or as I showed you, it could also mean EDTA. Then we do a reflexive replace time. If this is normal, then this combination of prolonged thrombin time, normal replace time is consistent with anticoagulant. But if both are prolonged, could be a fibrinogen problem, congenital or an acquired dysfibrinogenemia. And of course, it could also be EDTA. So I showed you a very complicated version of the cascade, and here I'm showing you a very simplified version. In the extrinsic pathway, you have factor 7. In the intrinsic pathway, you have 8, 9, 11, 12. And these two proteins, high molecular weight kininogen prekallikrein, and then you have the final common pathway. On a practical basis, I think this framework is all you really need to know in order to be able to be efficient and proficient in your practice. So coming back to the next case, it's a 45-year-old female. She had been admitted for gallbladder surgery, and the busy surgical resident ordered a clotting times. The PT is normal, APTT is quite prolonged. So that's enough to raise flags with the surgeon to try to figure out what's going on here. And the question here that I challenged my residents and fellows here, what do you do next? And I get all sorts of answers: mixing study, factor assays, this, and they are all potentially correct answers. But what you really need to do is get a hemostatic history. Find out if this long APTT represents or reflects an underlying bleeding disorder, which could be congenital or acquired. For that, you should, the next question I get asked is, well, what specifically in the history should I ask? It's very easy. There is an International Society of Thrombosis Hemostasis endorsed bleeding assessment tool. It's called the ISTH-BAT. If you just Google it online, you'll come across some online tools that you can very easily collect the information, and you have to add up a final score. So in this patient, the final score was 0. In other words, she's never had bleeding problems. The questionnaire goes through a variety of questions like dental extractions, surgery, heavy periods, childbirth, etc. Normal for men is 4 or less, and for women it's 6 or less. She had a score of 0, so she was hemostatically perfectly normal. So what do you do next after you've obtained the hemostatic history? After you obtain the history, you've got your baseline clotting times. The next step here is you do a mixing study with normal plasma. And then you repeat the PT and APTT. If it corrects, it's a factor deficiency. And then you have to perform factor assays, depending on which pathway is abnormal. You might end up doing all three pathway factors. But if it's inhibited, you have to determine what inhibitor you're dealing with. There are three broad categories as shown here. Could be drug, heparin, direct thrombin inhibitor. Could be a specific factor inhibitor like a factor 8 or a factor 5 inhibitor, because these specific inhibitors are bleeding risks. On the other hand, it could be a non-specific inhibitor like lupus anticoagulant, which is more of a thrombotic risk rather than a bleeding risk. So you can see it's very important to have the patient's clinical history in context and then do the right testing to be cost effective. Here's, coming back to our patient, here's her data. Long APTT, we do a mixing study, it corrects. Thrombin time was normal, indicating that there's no heparin contamination in the specimen. So factor deficiency, and what's the next step? You do the factor assays. So in this case, her 8, 9, and 11 were normal, but she had a pretty severe factor 12 deficiency. Now the question is, what do you tell the surgeon? Do you tell the surgeon to give plasma before surgery, to give recombinant factor 7, to do a preoperative plasma exchange? Or do you tell the surgeon proceed with surgery with no intervention? So the right answer here is D. And here's why. Factor 12 deficiency can markedly prolong the APTT, but it is not a risk factor for bleeding. The exact role for factor 12 is evolving, but it's certainly not felt to be a bleeding disorder. The other situations where you might get a prolonged APTT, but they're not bleeding disorders, is deficiency of high molecular weight kininogen and prekallikrein. Again, like factor 12, these deficiency states are not bleeding disorders. And then, of course, you have lupus anticoagulant, which is more of a thrombotic disorder. Moving on to the next case of a 45-year-old male who was diagnosed with melena and profuse diarrhea. A workup documented presence of inflammatory bowel disease, ulcerative colitis, in this situation. He received standard medical therapy. So now this is 1997. And back then it used to be steroids, 6-MP, didn't have the fancy monoclonal antibodies we do now. Now this was all diagnosed in another city, and he was advised to undergo a proctocolectomy. He came for a second opinion, and he was hospitalized. So here's his baseline PT. Here's his baseline APTT. Now, in the hospital, he received intravenous steroids. They gave him some red blood cells because he was anemic. His diarrhea overall improved, but it didn't quite completely, his melena resolved, but the diarrhea did not. So he had profuse, continuous diarrhea, for which the surgeon said, okay, we really do need to do a proctocolectomy. So they repeated the APTT here, and it had improved, but it was still prolonged by 2 seconds. Here's the reference range on the left. So again, the question, what do you do next? Well, as I said before, you really need to obtain a detailed bleeding history. Does this patient have a bleeding disorder, or is this completely asymptomatic prolongation of the APTT? In this situation, of course, he did have melena, but one wonders if that was ascribed to the ulcerative colitis as opposed to any bleeding disorders. So in his case, he indicated there was no prior spontaneous bleeding, there was no prior surgery, and then there was no prior history of thromboembolism. So the patient had come to up to 45 years of age without undergoing any surgical procedures. So you're at a crossroads here, and of course, there's no family history of bleeding either. Now, what do you do? Well, ideally, in the preoperative setting, I would say you should work that long APTT up. But because of his negative bleeding history, he was taken to the operating room without further workup, and he had a major hemorrhage. Within a few hours after, so he was oozing a lot more during surgery, but they managed to stop the bleeding. but then post-op, he developed the hemoperitoneum, which had to be evacuated. In the end, the finally testing was performed. There was no lupus or heparin. Mixing study corrected, and lo and behold, his factor assays showed a mild factor VIII deficiency. He essentially had mild hemophilia A, not diagnosed until he was challenged with surgery. What a situation. Well, I saw him myself about 6 months later, and I asked myself, gee, what did they miss here? Now, going to medical school in India, the one thing we were taught, you have to ask very good histories because patients may not understand the questions you're asking. And it's the same here in the US. So just the training in medical school was amazing that I had. So going into a lot of detail, I asked him, did you have surgery? He said, no. I said, have you ever had spontaneous bleeding like joint bleed or anything? He said, no. Then I asked him this one next question 3 different times. I asked him, have you ever had any dental extraction? He said, no. I said, have you had any teeth removed? He said, no. Then I said, have you had your wisdom teeth removed? He said, yes, all 4. So you have to ask the question in the right way. And he had had a dental extraction 8 years prior, and he had a bleeding for a week or 2 afterwards. So that really was a question that could have been asked. But more importantly, I think when you see a long APTT, like 45 seconds, I think it's important to work it up, especially in the preoperative case. His baseline factor level was 9%. So I advised all his male siblings get tested, and sure enough, 2 out of his 5 male siblings were tested and found to be affected with mild hemophilia A. And none of them had undergone prior surgeries, and in fact, they truly had no prior bleeding. This is not an exception, actually. This is the rule, and here's what it is. The patient history is the most important screening hemostatic test. It's easy to obtain, it's cheap, it doesn't cost any money. It might cost some time, but if you use the ISTH bleeding assessment tool, you can be very effective. You should always ask about tooth extraction, wisdom tooth extraction, dental extraction, independent of the question of surgical procedures. And so the history is critical, very important to obtain. I can't emphasize that enough. The other take-home message with this case, and each case teaches us something. Severe bleeding disorders generally present in childhood. Children start bleeding at circumcision, or when they start walking, they're bruising. But in mild bleeding disorders, you may not make the diagnosis till well into adulthood. So this individual was 45 years of age when we made the diagnosis. I have 2 additional mild hemophilia B patients we diagnosed when they were in their 70s. So it happens. Let's go a little into more detail on the lab aspect of his APTT. He had a fairly low factor VIII level. So why is it that his APTT, at least on the second assay, was only mildly prolonged? The question here one has to ask is, how sensitive is the APTT to factor VIII deficiency? So in this experiment, we took factor VIII deficient plasma, spiked it with factor VIII, and obtained a corresponding factor level and an APTT that's shown on the y-axis. You can see as the factor VIII level declines, the APTT lengthens, but it stays within reference range until you get down to about 30 to 40%. And then it starts prolonging. So the factor VIII level and the APTT have what we call a curvilinear relationship, not a linear relationship. And that's the challenging part because there are so many different APTT reagents on the market. And depending on what your hospital or what your lab uses, it may have a different sensitivity to prolongation depending on the reagents. So very important to know this information in your local laboratory. Same question you should ask with factor IX deficiency, factor XI deficiency as well. So to summarize, factor deficiencies with no bleeding risk, factor 12, high molecular kininogen, prekallikrein, and all of the factors really are risk factors for bleeding. So we'll move on to the next case of an acquired bleeding disorder. So this gentleman presented, he was a really healthy gentleman. He had had multiple prior surgeries, hernia repair, tonsillectomy, no bleeding complications. And in fact, 6 months prior to his current presentation, he had undergone an uncomplicated coronary bypass grafting. He was recovering well from his surgery. He was actually playing tennis, and he started noticing bruising on his arm where he holds his racket. I think he's right-handed. He went in to see his physician. He was very worried. CVC was normal. PT was normal, but the APTT was prolonged. So this is an acquired onset of a bleeding disorder that results in prolongation of the APTT. So next step, because he was bleeding, now we do a mixing study here, of course, and the APTT is inhibited. With his clinical history, you suspect a factor inhibitor, and so you go on to do the factor assays. And sure enough, he had a factor 8 that was quite low. This is a classical presentation for an autoimmune factor 8 inhibitor. The inhibitor was titered, so we do Bethesda titer, and it was 19 Bethesda units. So he had an acquired onset of an 8 inhibitor of 19 Bethesda units, which is considered high titer. Now, I do want to point out, this is a very hardcore lab aspect of 8 inhibitors. Sometimes when you do a mixing study with autoimmune 8 inhibitors, the APTT actually corrects into reference range. Usually upper reference range, 30, 31, 32, even 33 seconds. And that is because when you do the mixing study and you do the APTT right away, the factor 8 inhibitor may not have had enough time to inhibit factor 8. So therefore, you have to do an incubated mix. You incubate it for 1 hour and you repeat the APTT. And if it's an 8 inhibitor, it would prolong further, perhaps back up to 40 seconds or 45 seconds. Whereas with lupus anticoagulant, the incubated mix does not prolong. So that's one way in the lab to differentiate the two. Because we had the clinical history. Well, let me back up a little. So, the incubated mixes used to be done. Our lab doesn't do it anymore because all these factor assays have become automated and have become relatively cheap. So you might as well go to the diagnostic test, provided you have the clinical history. So autoimmune 8 inhibitors are immune-mediated inhibition of factor 8. Management really consists of maintaining hemostasis. The products available now are recombinant 7, and there's 2 types of products, factor 8 bypassing agents or recombinant porcine factor 8. So you maintain hemostasis while you try to eliminate the inhibitor using glucocorticoids initially, and you may have to add cyclophosphamide or rituximab, which is a targeted B-cell agent. Now, I'm just going to back up a little here. So factor 8 autoimmune factor 8 inhibitors are the most common acquired inhibitors. The next most common is factor 5 inhibitors. Now, this is the way to differentiate the two in the patient who's presenting with bleeding is that in 8 inhibitors, only the APTT is prolonged. The PT is normal. But if you have a factor 5 inhibitor, it's in the final common pathway. Therefore, the prothrombin time and the APTT will be prolonged. Now, what's interesting about 5 inhibitors is that not all patients have severe bleeding manifestations, and a number of them are discovered incidentally when routine clotting time tests are done. That's because platelets contain factor 5 and are protected from the 5 inhibitor. And so they're right at the site of where hemostasis is necessary. So again, not all patients with 5 inhibitors consistently bleed. Another point to emphasize here is what information do you not get from just the APTT test? Von Willebrand disease. So von Willebrand factor deficiency does not always prolong the APTT. It's not a reliable test to screen for von Willebrand disease. Note that von Willebrand factor is a carrier protein for factor 8. And if the von Willebrand factor level is low enough, whereby the factor 8 is low enough below the sensitivity cutoff for the APTT, then you might note a prolonged APTT. However, a normal APTT does not rule out von Willebrand disease. You always have to order a von Willebrand antigen and an activity assay of some type. Moving on to another category of inhibitors. So this is just a straightforward case of an unfortunate 22-year-old female who had one miscarriage and 2 years later had presented with visual disturbances, had an ischemic stroke in the parietal lobe, and she had some libido reticularis. So her lab data showed an inhibited APTT. So up here is the baseline, a mixing study inhibited. Then remember, lupus anticoagulant is an antiphospholipid antibody. So the way the assays are structured is that you add in excess phospholipid to the patient's plasma. In this assay, it's called the platelet neutralization procedure. We're adding platelets and it shortens. So the platelets, what they do is they absorb the antibody and therefore they neutralize the antibody and shorten the clotting time. And the next test that we do in our lab is a fairly sensitive DRVVT. And again, in the screen, mix was inhibited and confirmed it shortened, and therefore this is diagnostic of a lupus anticoagulant. So again, the APTT targets the intrinsic and final common pathway, whereas a DRVVT targets factor 10, not 5. This is an error in the diagram. So DRVVT activates 10. And because the APTT pathway is not involved, DRVVT is a much more sensitive assay. The criteria for diagnosis of antiphospholipid syndrome is presence of vascular thrombosis, arterial or venous, and pregnancy morbidity. Now, there's a variety of different miscarriage rates, so this is something for you to know. But in the setting of a clinical presentation that includes thrombosis and pregnancy loss, there are some lab criteria that need to be fulfilled. So presence of a lupus anticoagulant or one of the ELISA assays that are positive, so anti-cardiolipin or anti-beta-2 glycoprotein 1 antibody, IgG and IgM that are medium to high titer. Once you document this, it's important to document persistence. So the current recommendation is you should repeat the assays at least 12 weeks apart in order to fulfill the criteria for antiphospholipid antibody syndrome. So taking a step back, inhibitors, those that represent bleeding risks are autoimmune 8 inhibitors and 5 inhibitors, whereas inhibitors resulting in a thrombotic risk are lupus anticoagulants. I know I had 45 minutes, so I'm coming to some of my conclusion slides and some take-home messages, and I'll be happy to take questions at the end of this. So there are many take-home messages, and I find that throughout your careers, each case that you run across, manage, will teach you something about the patient and about the disease process. So I think with the cases that I've shown you, the variety of cases, it's clear that the APTT and PT are screening tests of hemostasis. So therefore, any screening test has its own sensitivity and specificity. And these APTT and PT can be abnormal in a variety of disorders, as I've shown you. A prolonged APTT may represent a risk for hemorrhage, thrombosis, or be of no hemostatic consequence. So don't always treat a patient based on a number. Look at the clinical context. In my opinion, I get asked quite often, when should you pursue a prolonged PT, APTT? When should you do mixing studies? And that's hard to answer when there are a variety of reagents and sensitivities out there. But my response always is, in my opinion, you should always pursue a prolonged clotting time, especially if you don't have an obvious explanation. And especially, I would add in the preoperative setting. The most important screening hemostatic test is very cheap and cost effective. It's the patient's history. Do the ISTH bleeding assessment tool. I will also be quick to add, however, that the absence of a history of spontaneous bleeding does not exclude a mild congenital bleeding disorder, as I've shown you in one of the cases, because they don't always present in childhood. They may not get exposed to trauma or surgery during their childhood or adolescent years, and therefore they only get diagnosed in adulthood when they undergo surgery. In a patient that's presenting with bleeding symptoms, it's very important to exclude von Willebrand disease. So don't stop at a PT and APTT and fibrinogen for testing. Always do a von Willebrand factor assay. The publications show a varying prevalence in the population, but up to 1% of the population is apparently affected with von Willebrand disease. And this is a high-level outline on how to approach a prolonged clotting time. Back in 2007, we used to get so often questions on how to do this. So one of the internal medicine residents, the last author is Kamal, Arif Kamal, and he and I wrote a review article in Mayo Clinic Proceedings. Was published in 2007. We made it open online access. So if you just Google it, Mayo Clinic Proceedings, put my name in and Kamal's name in, and you'll get it's free to download, to review. It's a very dense paper because we have to be very concise, but I think it's a very useful paper for practitioners. So in conclusion, prolonged clotting times can be due to artifact, can be due to an inhibitor. And again, there's 3 varieties of inhibitors to look for. Could be due to clotting factor deficiency, which may or may not represent bleeding risks. And then certainly could be due to drugs. I think I have about over 200 slides of cases, but I don't think that the time limit would allow me to go through all of them. So I think I'll stop here, and I believe it was 45 minutes, right, Dr. Agarwal?
Thank you so much. That was fantastic. Beautiful cases, very well discussed. It was absolutely a pleasure to listen to all this. And we will like to listen to your remaining 195 cases. We will call you off and on. So we have Indian faculty. They will like to ask you something, starting with Dr. Chandrakala.
Thank you, sir, for wonderful cases. Practical importance, actually, so many things we learned today. Sir, actually, I'm asking regarding thrombosis. What are the indications for doing a inherited thrombophilia workup, like protein C, yes? Or should we do it at all, or it is actually outdated, we should not do it? Or if we do it, which method, whether it's activity, antigen, molecular, because we have an opportunity now, we can do NGS also. So any because we do get a lot of patients referred for this, especially what is the indication?
That's a superb question. And the short answer, nobody knows. But I'll walk you through how clinically you approach this. I remember when I first came on staff, the DVT guidelines were heavily based on thrombophilia, 5-Leyden, protein C, antithrombin, things like that. If you look at any of the guidelines in the last few years, they don't even talk about thrombophilia. They approach it in a very clinical fashion, unprovoked DVT versus provoked DVT. Okay, for provoked DVT, expert opinion is you never do testing, and you only anticoagulate for maybe 3 months, maybe 6 months, you're done. Unprovoked, it's a little more nuanced. So unprovoked DVT in males, it's been shown that they have, after you treat them with whatever duration of anticoagulation you've decided, if you stop anticoagulation, they have up to 9 to 10% annual risk of recurrence. Is doing thrombophilia testing going to change your anticoagulation management plans? Probably not. You'll anticoagulate them for the long term, provided your bleeding risk doesn't exceed the recurrent thrombotic risk. Now you come to women. Women seem to be protected from recurrent thrombosis, but there's a very good scoring system that the Canadians have come out with. It's called the HER2 scoring system. It's online on MD-Calc. So MD-Calc, by the way, is a really good tool. I use that a lot. And if you have a score of 2 or higher, your recurrence risk is equally high compared to males. So long-term anticoagulation is probably the way to go. But if you have a score that's less than 2, your recurrence rate is 3% or less per year, and therefore you can give them time-limited anticoagulation. That's the high-level clinical approach. Now, my own opinion is because, one test that I do in most people is lupus anticoagulant and antiphospholipid antibodies. Because as you probably know, the literature now shows that if you're triple positive, lupus anticoagulant, beta-2, and the cardiolipin, the DOACs, so the are not good enough, and you really need to treat them with warfarin. That's a very practical approach. Having said that, there's always this part that the patient's desire to know, well, I have family members, so many family members with thrombosis. What does my family have? So then we work with them, and I personally do sometimes do testing in that situation. And then to answer your question, now we have a panel approach here. We say, if you're going to do one test, why not do all of the tests? Because remember, venous thrombosis is a multifactorial disease. So the patients might inherit more than one thrombotic thing. I prefer to do it remote from anticoagulation. So I stop the anticoagulants for 3 to 4 weeks. If I'm really worried about recurrent thrombosis in that period of time, I bridge them with heparin. And then we advise you do the activity assays first. And then for the 5-Leyden, we advise you do APC resistance. It's much more cheaper to do it that way. So you can see it's a very clinical approach, using the laboratory very judiciously. And I know I shouldn't say that. I direct the lab, so I lose business, but that's okay. We need to do what's right for the patient.
Yes, thank you, sir. Thank you.
Thank you, Dr. Chandrakala, and thanks, Dr. Rajiv. We'll take a related question. Dr. Raj Warrior wants to know, can you comment about the lupus anticoagulants and its significance in children?
That's a really good question. So Luke, the reason the antiphospholipid criteria, they say you should reconfirm persistence in 12 weeks is because a lot of the times these antiphospholipid antibodies are transient. They occur after infection, coughs, colds. In children particularly, the most common scenario is the child comes in for a tonsillectomy because they've got inflamed tonsils and APTT is prolonged. So they cancel the surgery and it happens to be a lupus anticoagulant. Majority of the time they're transient. It's rare that they become persistent and cause pathologic thrombosis.
Thank you. Dr. Mukul, your question.
Thanks for the wonderful case-based discussion. They are always a pleasure to listen. So my question is with respect to thromboprophylaxis. As a practicing hematologist and a hemato-oncologist, which VT prophylaxis score do you advise? Corona score is usually kind of not advisable for hematological malignancy. Vis-a-vis any other score, I score or any other thing like that. And a corresponding part would be how do you approach such patients of myeloproliferative disorders with respect to their anticoagulation if they have or not have a prior venous thrombosis?
Yeah, excellent questions. So for the venous thrombosis prophylaxis, were you asking specifically for hematologic malignancy?
Yes, sir.
Okay, yeah. It's a challenge because thrombocytopenia is very common, right? And so there's the clinical approach where those scoring systems I don't think apply very well to the hematologic malignancies. So we risk stratify. When the patient first comes in and if their platelet counts are normal, we do give them low molecular heparin DVT prophylaxis. As the platelet count declines, then we sort of back off on that and we eventually completely stop it, but we provide mechanical methods. Now, that's the clinical approach. The reality in the regulatory bodies in the US is, it's the Joint Commission. And if you don't provide DVT prophylaxis, or you don't provide a justification for why you didn't give DVT prophylaxis, the hospitals get dinged, they get fined. So our order sets contain a mandatory mechanical methods, but pharmacologic, they say they advise it, but if you don't select that option, they say why. And most of the time it's thrombocytopenia. So that's the group with hematologic malignancies. It's even more of a challenge for lymphoma patients who developed DVT because it's so common. And then they come in for the refractory, lymphomas, they come for high dose chemotherapy, they're going to get thrombocytopenic. So from therapeutic doses, once their platelet counts drop to 50,000, we go to prophylactic doses. Once it drops below 20,000, we stop it. So that's kind of there's some guidelines now that are suggesting that. I believe one of my colleagues brought it to my attention. I haven't actually looked at that myself. So for the myeloproliferative neoplasm patients, it's again risk stratification into low and high. I think there's an intermediate risk stratification, which I'm not sure what the difference is between intermediate and high. It's either low or non-low. So aspirin is used very commonly in the right setting. So previous history of venous thrombosis or high risk with other major cardiovascular risk factors. I don't think they're used, my colleagues in MPN specialty are using DOACs empirically, but if you develop a venous thrombosis, they certainly are starting more and more to use DOACs rather than warfarin.
So just a corresponding question. Would you consider MPN as a persistent risk factor or a kind of a provoked risk factor for which a limited duration anticoagulation be given?
Yeah, so the incident event in the setting of myeloproliferative neoplasm, we consider it persistent.
Persistent. Okay. Thank you.
You may control the hematocrit, but there's so much of the biology of the disease that
Yes.
you don't quite know. Yeah.
Thank you, Mukul. One question from the audience. Dr. Velu wants to know, if you have a thrombotic event, how long do you wait before testing for antiphospholipid antibody syndrome?
Right. So there's two ways to approach this. When you have the acute thrombosis, you could go ahead and before you start anticoagulants, you could collect the sample and send it at least for lupus anticoagulant, because the anticoagulation therapy interferes with lupus anticoagulant testing, but it does not interfere with the ELISA assays. Or you could just give them the appropriate duration of therapy, stop the anticoagulants minimum 1 week, and then test them for lupus anticoagulant. So that's for lupus anticoagulant, minimum 1 week of anticoagulation. For the ELISA assays, the anticoagulants don't affect the results. You could counter that by saying, but if the patient has triple positive, you would be treating with warfarin rather than the DOAC. So that's why we're at that crossroads now. Should you be testing right up front in everybody and then putting them on warfarin if they have triple positive and then retesting them later on? That's certainly a reasonable approach.
Thank you. Dr. Aditi Jain, your question.
Good evening, Dr. Pruthi. I have two questions, and one of them is a case which we are treating in our hospital. She's a 35-year-old female. She's had recurrent episodes of anemia and thrombocytopenia for the past 3 years, 1 episode per year, and each episode has subsided with just transfusions. She hasn't been evaluated or treated with anything specific. For this third episode, she came to us, and her PS had schistocytes, and in a TTP workup, her TS13 came out to be less than 10%. The inhibitor level is not available. But because of her recurrent history, and it was a mild kind of history, we thought it could be a congenital TTP, and we did a TS13, but the NGS is negative. So we are probably dealing with an acquired TTP, but this episode also subsided with just supportive care. And in fact, we just gave her FFP once, and she's improved. She's completely asymptomatic. She has no evidence of hemolysis at present. So my question is, how would you manage this patient? Would you give preemptive immunosuppression from now, or wait for the next episode? And would you give steroids plus rituximab or without it?
Wow. Yeah, it's a very interesting case. So how far apart were the episodes?
So around once a year. And the first episode was in postpartum period when she had her delivery. And after that, she's been having yearly episodes.
Yeah. So did I hear you right? There was no gene mutation.
Yes, by NGS, no gene mutation.
But no inhibitor either?
Sir, actually, inhibitor levels are not being done anywhere. I'm still trying to find out, but we've not been able to do a inhibitor assay.
Yeah.
But levels are definitely low.
They are low, yeah. And yet she's completely normal in between episodes,
Yes.
Right?
Yes, right. After this episode, we've been monitoring her. We actually discharged her after sending the gene assay, thinking she'll come out to be a congenital TTP, and she's completely normal. She's come multiple times. It's been around 8 weeks now, and her CBC, LDH, retic is all completely normal.
Boy, if she's completely normal, it's really hard to justify giving her toxic drugs, right? In between episodes. But have you been monitoring her frequently in between episodes to check her platelets and LDH and things like that, or no?
So this is the first episode in which she's come to us. The previous episodes were treated at some local center with no specific workup.
Yeah.
The problem is actually we can't do TS13 level also again and again because of monetary constraints. but one level was definitely low. And if we correlate with someone who's been treated and we keep on monitoring levels and it falls and then we treat again for an acquired TTP, I was just trying to correlate because she does have 3 episodes. So I don't know if we can just let it go.
Yeah, because one episode in the future she might have devastating thrombotic complications, right? Strokes and things like that. Boy, and it's expensive drugs as well, isn't it? So
Yes.
I'm not sure I have a good answer for you, to be honest. And we rely heavily on lab assays here to make those decisions. I'm happy to try to help if you want to send me an email. I would probably monitor her carefully. Maybe since you've only seen her for the first episode, I'm not sure I'd jump in with immunosuppressants at this stage, but maybe sequentially just do the simple tests, LDH, platelet count, and see how she's behaving. But at the next early signs, if she's going to have a relapse, maybe that's the time to jump in, because then now that's the second time you're seeing her, and then you have the data in your own hospital and lab, and you can justify giving her expensive drugs, I think. So
yes, fair enough. Thank you, sir. I have one more question. Lately, I've seen 2 patients of distal symptomatic unprovoked DVT, and how to manage those patients.
how old is the patient?
They are both young, sir, 25 to 30 years. No family history.
Yeah. And were the events both in the same leg or bilateral, or?
No, 2 patients with single episode of distal symptomatic unprovoked DVT, not recurrent yet.
Single episode. I got it. Okay. We treat them 6 weeks. We used to say, well, do another ultrasound. If it's not progressing, leave them alone. We leave them on the data in the New England Journal that was published was with fondaparinux. It's an injection, but I think you can just give them a DOAC. I imagine DOACs are available now, rivaroxaban, apixaban in India as well.
Yes.
They're symptomatic, they're painful. I would treat them for 6 weeks.
So not prolonged though, because they were unprovoked and symptomatic. No. And no workup required.
They're young, right? So, boy, I'm not sure. I've certainly had some young patients with recurrent superficial thrombosis, and they have 5-Lydin and prothrombin. Now, what do you do with that? So, but if it's symptomatic recurrent, of course, then long term, I just go with the practical clinical presentation. The unprovoked data is for proximal deep vein thrombosis.
Yes.
And the recurrence. Yeah.
Yes. So, thank you so much.
Just to intervene for that question only. So if this patient had a recurrence of a distal DVT, so that will qualify as recurrence and will require a prolonged anticoagulation, if I understood correctly.
Yeah, I think you balance the risks and the benefits, right? So I don't think there's good data to tell you the recurrence rate of distal DVT that's unprovoked. Nevertheless, the patient in front of you has had a recurrence, right? So individualized management, you could probably prolong it for another period of time and then stop it. And I think it's a discussion with the patient, because it's cost of the drug, cost of the bleeding risks. If they bleed, you have reversal agents. Warfarin is inconvenient. So as an example, and this is just hypothetical, the first event you could treat for 6 weeks, like I said. If they have a second event, that kind of also depends on the timing of the second event. If they don't have a second event for years later, again, you could give them a short term. But if they immediately have a recurrence, that's telling you there's something wrong with the patient, right? You might want to extend it 6 months, a year. Again, negotiation with the patient. Do you want to stay on it? Do you want to stop it and give it a try? It's different if it's a pulmonary embolism as opposed to a distal DVT, right? The consequences of recurrence are much more serious. So it's so nuanced and individualized in that situation.
Sir, actually, sir, can I ask one question? Same thing.
Sure.
Sir, do you use D-dimer to decide the duration of anticoagulation in any of your patients?
Yeah, yes, I do. So the HER2 scoring system includes a D-dimer as a measure. So that's only for women. As I said, for men, it's become such that if it's unprovoked, I just leave them on blood thinners. But there are some patients that don't want to be on anticoagulants. I do in that situation use the D-dimer. So we stop anticoagulants. 6 weeks later, we do a D-dimer. I mean, this is anecdotal, so I can't tell you that, there's literature that's published, and some people are skeptical of that literature, but for me, anecdotes are fine. But I also check a couple of other things. D-dimer, I also check a fibrinogen, because elevated fibrinogen levels are a risk factor for recurrence. Now, my own way of doing things is I also look at von Willebrand factor, which is a surrogate for endothelial activation. So I do all three assays, but it's anecdotal. I can't quote any literature, but it's for the patient who really insists, look, doctor, I want to get off my anticoagulants. And over the years, there have been 1 or 2 patients I've said, okay, here's the data. And when you show the data to the patients, then you convince them, okay, this is high. You will have a recurrence. I just don't know when. And then they go back on it. At least they're satisfied that we've tried.
Thank you, sir. Thank you.
Thank you. Dr. Anand Prakash from the audience wants to know, how do you decide which patient of ITP should be investigated for antiphospholipid syndrome?
I forget what the latest guidelines say, but in my practice, I look every patient with ITP, I'm looking for antiphospholipid antibodies. I think its prognosis is different, and there's always a risk for thrombosis in ITP. I wouldn't necessarily anticoagulate them, but I think it's good to have that information. It's like looking for secondary ITP, right? Because ITP, the way it stands, autoimmune idiopathic thrombocytopenia, is a diagnosis of exclusion. So I think it's important to exclude SLE, other connective tissue diseases, and antiphospholipid antibodies.
Sir, in these patients, do you avoid thrombopoietic pneumatics? Sorry, sir, actually, I didn't ask your permission. Yeah.
Not necessarily, because the natural history of this is still yet to be defined. So again, the studies may be biased. You have ITP patients with thrombosis who are found to have antiphospholipid antibodies. But what about prospectively all ITP patients with antiphospholipid antibodies? How many of them develop thrombosis? I don't think there's good literature out there on that.
Thank you. Another one audience question is from Dr. Afaq Ahmed. After you have a patient of DVT and you do a follow-up sonography, and it shows the features of chronic DVT, incomplete recanalization, what is the impact of that on your decision of duration of anticoagulation?
Right. So we discussed this with our vascular colleagues quite frequently. There's some data out there looking at, greater than a certain percent of the lumen, less than a certain percent as predictors of recurrence. Our vascular group doesn't quite buy into that, but anecdotally, our ultrasonographers are actually quite good at saying that, okay, this is chronic, it's completely chronic, or saying, well, this looks subacute. So anecdotally, we just kind of extend anticoagulation and we repeat the testing. So in general, there's some data to support extending anticoagulation based on finding of a chronic clot. In that situation, I'm also doing a D-dimer to see, okay, is that clot really active? I mean, is there still ongoing thrombin generation? And if that's the case, then we do for sure extend anticoagulation.
Thank you. Dr. Ankita Singh.
Thank you, sir. Thank you for the very detailed presentation. I would like to ask you regarding one of my patients. So we are currently treating a patient of severe hemophilia B who has developed superficial thrombosis in one of his arms, just immediately after blood drawn for some other event. So, so how would you say we go about treating this patient?
So was it in a basilic vein or a cephalic vein or one of those veins in the arm?
The cephalic vein. The cephalic vein.
Yeah. Does it extend into the axilla?
No, sir, it does not. It extends somewhere up to the middle of the forearm and arm. So, and it's the Doppler shows the extent to be midway between the arm and forearm.
And is he on prophylaxis infusions, or is he just on no prophylaxis?
So this child is 9 months old, and he was not on, and he's severe hemophilia B, but because he is pretty young, so he's recently diagnosed and not yet on prophylaxis. So post this event, we started him on prophylactic factor 9 as well as LMWH just to counteract, but we are not quite sure. Like, we would like your opinion regarding this.
Yeah. Sorry, what was the second drug you mentioned?
LMWH.
Low molecular
Oh,
weight.
molecular heparin. Got it. Okay. I think that's I would have done exactly the same. Probably for a limited duration with the low molecular weight heparin, right? Because you're stuck now. You have this clot. You don't want it to extend because it could have devastating problems. But it's kind of unusual. And this the provoking event was a venipuncture, was it?
Yes, sir. Because immediately after the blood was drawn, I believe within half a day, the child came back to us and his hand was swollen. So we worked him up and we found.
Does he have any congenital? I mean, this is 9 months old. Does he have any, like, up here in the thoracic outlet or something like that?
We haven't really worked him up for that, so I could take a look at that. But the thing is, sir, we wanted to send him for congenital thrombophilia workup, but maybe after the acute episode subsides, we wanted to send the mutation panels for the two commonest ones, but they cannot afford the test, so that is still on hold. So is it advisable to do the test, and whether LMWH, like how long, since he's already been on low molecular weight heparin for 5 days. So how long should we maybe proceed with it?
I'm not certain doing the molecular testing would help in management, to be honest. When somebody, so upper extremity venous thrombosis, most of the time it's due to anatomical abnormality. Again, in adults, it's catheters, right? Young adults, it's due to thoracic outlet. I've never heard of a 9-month-old getting this, but the provoking event seems to be the venipuncture. I would look more up here to make sure. So you have to go for the diagnostic. So I don't even know if thoracic. I'm not a pediatrician, so thoracic outlet in a 9-month-old would be distinctly unusual, but I think you don't have a good explanation. So that's the diagnostics. The therapeutics, I would do low molecular heparin for maybe 6 weeks, and then do another ultrasound to see what's happening to that clot. Now, if anything, for a young, 9-month-old, I'm not sure the 5-Leyden prothrombin would really be relevant here. I would be thinking more like congenital protein C deficiency. And that's a challenge making the diagnosis, because pediatric patients have a different reference range than adults do. So you could send off a protein C activity, which I suspect would be cheaper than a molecular test, because that's the only thing that comes to mind. The worst case scenario, you think of purpura fulminans, right, in a congenital protein C deficient or meningococcemia. And of course, the question is, what would you do with that information, right? At least you'll make
especially
it
in a severe patient. So, right.
Yeah.
So if I do have to send for a protein C or S level, so after how many days should you suggest that I send for the panel?
So if it's a chromogenic protein C, the low molecular heparin shouldn't interfere. And in our lab, for the protein S, we do the free protein S and the total, because the activity assay is not a very good assay. So that should not be interfered with by the low molecular weight heparin. So diagnostically, again, it may not change the short-term management because you're already on low molecular weight heparin. It may be important, but now I guess important here is there a family history here? Parents, grandparents?
No, nothing that they can come up with. No.
So the likelihood is quite low, isn't it?
We were quite surprised, and we are actually very skeptical because he's a severe hemophiliac and we're treating him with more anticoagulants. So it's like a thin line here.
I should ask then, are his other vitamin K dependent factors normal? Did you check anything else? Or?
So his LFT, his liver function test is normal, and we didn't really send for anything else, but his PT was normal. and we haven't really checked for anything apart from factor 8 and 9. So I could maybe take a look at that. We could send for those.
I'm just thinking of the very rare combined congenital deficiency of the vitamin K dependent factors. That's a carboxylase mutation or VCORC mutation. But they don't generally present with thrombosis. They usually bleed.
Right.
So very unusual case.
Okay, thank you. So maybe I can work up and send for the protein S and C and take a look. Thank you.
Thank you. One question from the audience. Dr. Christopher wants to know, in a case of ITP with antiphospholipid syndrome who has developed an overt thrombosis, at what level of platelet count you are comfortable using anticoagulants?
So it really depends on the patient's phenotype. So I rely a lot on the clinical presentation. But just to go with a number, 50,000 or higher is felt to be sort of the appropriate approach. Now, if you're not able to maintain a platelet count of 50,000 with the initial therapies, what I've done anecdotally is you try out the different drugs that work. Certainly the TPO agents. So you balance the TPO agents. There's a theoretical thrombotic risk that's really in ITP patients with platelet counts that are over 500,000. But then you're balancing that with the anticoagulant treatment. So I think that balances out well. There are some patients you have to give them regular infusions of IVIG, to keep the platelet count high enough in order to anticoagulate them. Now, it's very frightening to have a patient with 20,000 platelets and massive thrombosis. I mean, I've had that with some of my patients, IVC thrombosis, pulmonary embolism. So it's a serious condition. And then the concern of IVIG-induced thrombosis, that's also one of the factors that's a provoking event. But I guess if you're able to maintain above 50,000 and keep them on anticoagulants, the patients should be sort of balanced out, I think.
Another question from audience is Dr. Arihant Jain wants to know the duration of anticoagulation for cortical venous thrombosis with no unprovoked cortical venous thrombosis.
Oh, very common scenario. It's and a really tough one. Most of the time it's provoked. So the good news is you can sort of give them a time-limited anticoagulation. But if it's unprovoked, I think you really, and you're convinced there's no other underlying reversible factor, then long-term anticoagulation is the way to go. Now, I will say, though, it's very important to make sure that the radiologist that made the diagnosis is experienced. I can't tell you how many times we see patients with referred with the diagnosis of persistent, cerebral venous sinus thrombosis. They come here, our radiologist looked at this and says, there's no thrombosis here. This is a congenital anomaly. And so make sure the right tests are done. And so even MRIs are so specialized, I didn't know. And the right radiologist looks at it.
Thank you. Dr. Ruchi Khanna.
Thank you, sir, for an excellent presentation. And it is my pleasure to know that you were a part of Manipal. Sir, I just have a few questions. The first is, what is your experience on asymptomatic DVT and how do you screen such patients?
What context would that be? Post-op or?
So, no, sir, not post-op, pre-op. How do you know? Suppose because if they are DVT patients, those who are not symptomatic, so how do you screen that? How do you know? Is there anything which supports, like beforehand, if a person knows that a person is going into DVT because I read something about asymptomatic DVT. I just had a question whether what is your experience on that?
Yeah, we don't usually do routine screening in the pre-op setting. So that's the one scenario. There was a clinical trial that Dr. Khurana did looking at patients with going for cancer surgery. The D-dimer was done in all of them. And actually a very high percentage of those patients had an asymptomatic DVT. But that's the only context one would be concerned about it. But otherwise, there's no role for routine screening.
Okay, thank you, sir. And one more thing, is there any fixed duration? When should the blood test be performed after an acute thrombotic episode? As you mentioned, 3 or 4 weeks.
For the thrombophilia testing, you mean?
Yes, sir.
Okay. Ideally, the one test I do before you start anticoagulants is lupus anticoagulant. And the ELISA assays for antiphospholipid antibodies you can collect anytime.
Okay.
However, if the patient is already on anticoagulants, then you decide whatever duration of therapy you complete. For lupus anticoagulant testing, minimum 1 week off anticoagulation before you do the lupus anticoagulant testing.
Okay, and so one more question. How do you prevent neonatal thrombosis?
So these are premature neonates, are they?
Yes, sir. Premature neonates, those who are on catheter. Yes, sir.
I have to admit, I'm not a pediatrician, so I'm not sure what the usual practice is. I don't know if they give prophylactic anticoagulation. I'll be very honest. I know. Does anyone else know? No.
Okay, sir.
Sorry
Thank you,
about
sir.
that.
No, sir. I just had a query, so out of interest, I asked. Okay, thank you so much, sir.
Thank you. Another question from audience. Dr. Ganesh has a 50-year-old hemophilic who is on regular prophylaxis, and he has now developed acute myocardial infarction. How do you manage this patient?
Yeah, so yeah, that is a real challenge. What I tell the cardiologists here is that we're going to give the factor. You treat the patient how you think the patient needs to be treated. I advise them, if you're going to put a stent, to put in a bare metal stent, because then you can limit the duration of antiplatelet agents. Most of the time, however, patients' heart disease is so bad they go for a coronary bypass graft. Now, after that, if they need to be an antiplatelet agents, typically it's aspirin. We maintain the factor VIII level at about 20 to 30%. Because a lot of you look at the mild hemophilia population, they're not protected from heart disease. And yet I put a number of my patients on aspirin because of, the cardiologist wants it. They actually do fine. So when you have 20 to 30% factor VIII levels, antiplatelet agents are safe. It's rather expensive. Now, what's going to change is this emicizumab has come, right? Hemlibra. Is that going to make it easier? Perhaps. There's no data. No, I don't even have anecdotes on that, but we'll see how that goes.
Dr. Tejaswini.
Thank you, sir. Thank you for the invite. Sorry for the lighting. There has been a power cut here, and I have quite a few questions. I wanted to know whether there are definite guidelines for diagnosing Gardner-Diamond syndrome, or whether it is a diagnosis of exclusion. Suppose
it's a tough diagnosis. It is a diagnosis of exclusion. We published our series from Mayo, had about 75 patients, and the history is the most important. Patients present with bruising, but before they notice the bruise, they have prodromes, and it's described as stinging, burning, stabbing pain in the area where the clot is, where the bruise is going to form. We still do extensive testing, which should be negative, and then you're left with a diagnosis of exclusion. In your history taking, underlying this, you need to get a sense of whether there's some anxiety, abuse, something psychological underlying all of this. We had one patient that, one of my colleagues follows, dramatic Gardner Diamonds. She's sitting in his office. He was visiting with her, just talking. And then she looks at her calf and says, "Oh, I feel something in my calf." He takes out his camera and he takes pictures intermittently, and the bruise is forming right there. Within 30 minutes, there was this large bruise. The same patient was admitted to the hospital, and I think she had a lot of pain, and she happened to be in an abusive relationship with her daughter. That was the triggering event. The hospital service told her, "Okay, we're going to dismiss you today." Right away, she developed a large bruise on her right thigh. They came back 2 hours later and said, "Well, we're going to keep you another day." Within 30 minutes, the bruise was gone. I have no idea what the pathophysiology of Gardner Diamond is. It's mind-boggling. but it's a diagnosis of exclusion.
Okay.
You have many questions, right? Go ahead.
So recently we were seeing one patient with hypertrophic cardiomyopathy who had GI bleeding. So I was going through all the articles that you have published along with your residents and other colleagues. So I saw that there was one where you have described GI bleeding disorders in HOCM. So I wanted to know about that.
Yeah, so I think for many years, the relationship between aortic valve stenosis and GI bleeds has been recognized. That's called Hades syndrome. We now know the pathophysiology. So the severe stenotic valve shears the high molecular weight multimers. And it turns out the high molecular weight multimers have an anti-angiogenic effect. So when you shear them, you have angiogenesis. I don't know why, but there's a predilection for the GI tract to develop those malformations. Similarly, it's been recognized now, other cardiac malformations have a similar predisposition. So the hypertrophic cardiomyopathy is one. And then, we've seen some patients, and my colleague actually has done more in the lab, has done more research on that. And we've shown the shearing, the multimer pattern shows a loss of the high molecular weight multimers. Sometimes it is so subtle, it's not an obvious loss. But the bottom line is you go fix the valve, you go fix the myocardium, and that completely resolves or reverses the GI bleed. And then when you repeat the multimer analysis, you can now in retrospect see, oh, before the surgery, there was a slight loss. Now after surgery, it's completely normal. So that sort of tells you the correlation. There's a group from England that has done some very nice mouse model studies, and they're the first ones that described it. Now, also mitral valve is found to be the same thing as well. So it's a fascinating area. I think the true function of a lot of the clotting factor proteins are still being discovered, and von Willebrand factor is one of them.
Thank you. Any other question, Dr. Tejaswini?
Sir, I was reading going through all the articles that you have, that is listed on the this one. Is there any role of working up for platelet disorders in every hematological malignancy? That is one thing.
That's a really good question. That's an evolving, emerging recognition. So I think what you're describing is some congenital platelet disorders have a predilection to myeloid malignancies, right? Mm-hmm. And so now you end up with somebody with a myeloid malignancy. Now should you work your way backwards? Mm-hmm. I think the simplest, most cost-effective way of approaching that is you look at that patient's previous blood counts, if they've had any. And then you obtain a family history. Okay, is there a family history of myeloid malignancies, things like that? And if so, now the expensive approach here would be you could do next-gen sequencing for platelet panel. But I think on a practical basis, I would inform the family members and have them have their blood counts checked and monitor them. And if there's any sign of a myeloid problem, have that investigated. But not only that, the Hermansky-Pudlak syndrome, there's pulmonary fibrosis. There are some Fechner syndrome, there's renal insufficiency and need for renal transplants. Not too long ago, I was referred a patient who was mildly thrombocytopenic. She was sent to me by the kidney transplant team to evaluate as a kidney donor. So she wanted to be a living related kidney donor for her sister. So that means her sister's had renal failure and has failed a previous transplant. So I went back into the patient in front of me, and she had, I did next-gen sequencing, and she had, I think it was, I forget what mutation she had, but I said, I can't okay you as a kidney donor because in future, you may need a kidney transplant yourself. So let's just, it's bad for your sister, but for you, I think I need to preserve your kidneys. But the only way I could do that was because she was screened with a thrombocytopenia, and that's how it was detected. I don't know that you need to jump straight to next-gen sequencing in every patient.
Okay. Thank you. A question from audience. Dr. Arihant wants to know, how aggressively do you investigate for an occult malignancy in an elderly person with acquired hemophilia?
Very good question. So acquired hemophilia, if you look at the data, the large majority are idiopathic. They don't really have an underlying secondary cause. For those that are elderly, there's a higher risk of malignancy. I just do the standard age-appropriate screening, whatever the guidelines recommend. And then you're left with the patient's symptoms and signs. If they have unexpected weight loss, if they have GI symptoms, then you might want to do targeting case detection. But and again, I'm breaking it up into some very fine details. There's screening, so the patient has no symptoms. Go with the standard screening guidelines. There's case detection, you go with the patient's symptoms. Now, having said that, we have about 80 autoimmune hemophilia patients in our practice. Only one of them had an esophageal malignancy, but then she had symptoms when she presented, and that's why we investigated. So it's rare in our experience.
Thank you.
Can I?
Yes, yes.
Oh, would the same apply to, instead of an acquired hemophilia, would that same apply to a DVT patient, elderly DVT patient?
Yeah, so if you look at the studies, there's more studies for DVT actually. And if you look at the case reports, the prevalence of malignancy in those less than 50 years of age it's pretty rare, few percentage. And above 50, it varies from 10% to 25%. So those are cases that are published in case series. There have been some prospective trials looking at unprovoked DVT and looking at and they're very tough to recruit. So some of the trials shut down, sooner than others. Here's the take-home message. Go with standard screening guidelines that are age appropriate, like I said before, for autoimmune hemophilia, and then case detection for symptoms. That's the best I can say. But doing in-depth testing like upper lower endoscopy, screening CT scans, PSA, it's really not been shown to prolong survival. You may detect the malignancies at a slightly earlier stage, but it's not statistically significant.
Thank you, Dr. Mukul. Dr. Ankita Sen.
Yes, sir. Thank you. Sir, I wanted to ask you something. We get a lot of gynecology consults regarding women who are undergoing in vitro fertilization and anticoagulation. So I would like your thoughts on anticoagulation for such women.
Oh, so empiric anticoagulation for prophylaxis? Yeah.
Yes.
That's a good question. We're actually looking at our own data now. I have to admit, I'm not very involved in that practice. So I hesitate to give you one recommendation or the other to see what our maternal fetal medicine. So our maternal fetal medicine group handles that. They don't even consult us. So.
Okay. Okay, because there's a confusion because a few groups actually go ahead with anticoagulation, and some of them ask for our opinion, and without a thrombophilia history, we are not quite certain about what to do about it.
I think that's reasonable. So if there's no previous history or no family history, I guess my approach would be to just watch, but recognize the ovarian hyperstimulation is quite thrombogenic as well. So if you have some risk factors, it turns out obesity is a pretty big risk factor for venous thrombosis. So maybe in a subgroup of high-risk patients, you might want to empirically anticoagulate.
Okay. Thank you, sir.
Dr. Chandrakala.
Thank you, sir. So regarding this is portal vein thrombosis, we do get patients of portal vein thrombosis with collaterals and then diagnosed after collaterals as actually portal vein thrombosis. And how should we approach these patients? And we also get patients, young patients with the ischemic bowel disease, like arterial thrombosis. These are the two problems we face, and how should we manage these two patients?
Yeah, the portal vein thrombosis is a very common problem. And so if you make the diagnosis of acute portal vein thrombosis, we don't necessarily anticoagulate them forever. We sort of give them time limited, assess for risk of recurrence. For those that present to you with chronic portal vein thrombosis, as evidenced by collateralization, that's really tough one. So if you can somehow, with imaging studies, determine if it's sort of an active thrombus, you might anticoagulate them for a short period of time. In that group of patients, they invariably have varices as well. So the risk of hemorrhage is pretty high. And so we don't give them long-term anticoagulation. So we sort of dichotomize it that way. Now, if they have a persistent risk factor like myeloproliferative neoplasm, which is a very common, scenario, or PNH or something like that, then we do continue anticoagulation, but we do it very carefully. What do I mean by that? I have no idea. I mean, we watch them frequently. We ensure if it's warfarin, their INRs are maintained, but now we're using more and more DOACs. That's a double-edged sword because they are high risk of bleeding. If they come in with a variceal bleed, the DOAC reversal agents are so expensive. So we work with our GI colleagues to see if we can, ban those varices, sclerose them or something to reduce the risk of hemorrhage. The arterial thrombosis is a really big problem, and particularly to the small bowel, right? Is that what you meant? Small bowel, yeah.
Yes, sir. Young patients suddenly coming with pain abdomen and then consultation from surgeries, that ischemic bowel disease, and then surgery. So,
yeah. On a high level, the young patient with any arterial thrombus, and we see the bowel thrombus, we see renal infarcts, always make sure you're not dealing with a vascular dissection. That is a completely different type of a disease. They might have fibromuscular dysplasia. We still anticoagulate them, but it's not long-term anticoagulation. But if it turns out to be a true embolic event, then you have to look for a proximal source. And again, I don't know that there's good case series to tell you what the different sources are. And again, we're talking about a young patient, so it's likely not atrial fibrillation, with an atrial clot, but could it be a PFO? Could it be some sort of a cardiac shunt or a pulmonary shunt? I've seen one case of a pulmonary shunt. In that case, you probably are left with anticoagulating for long term. Then, of course, look for, in the elderly patient, you always have to make sure you're not dealing with atrial fibrillation and thromboembolic disease.
the same thing with the Budd-Chiari syndrome, hepatic vein thrombosis. Actually, you give a short time or a long term anticoagulation, sir.
Yeah, so for Budd-Chiari, always make sure you're looking for a myeloproliferative neoplasm, PNH, and if they don't have that, I think they're doing long-term anticoagulation. Yeah, because otherwise the consequence of recurrence is pretty serious. You need a liver transplant, right?
Yeah.
Thank you, sir.
Dr. De Silva wants to know your policy of anticoagulating retinal vein thrombosis.
We don't. I don't know what retinal vein thrombosis is. I've had my patients with von Willebrand disease and hemophilia who come into retinal vein thrombosis. They're already anticoagulated, right, with their factor deficiency. I think it's more of a acquired risk factors, hypocholesterolemia, smoking, hypertension. At the most, we give them aspirin. That's it. Now, if you have antiphospholipid antibody syndrome, it's a different ballgame. For them, we do put them on warfarin anticoagulation. Yeah.
Thank you. Dr. Raj Warrior wants to know what is the status of thrombin generation test as of now.
Mm-hmm. Yeah, we're struggling with that because it's not well standardized. I think the instrumentation and the techniques are improving. So there are labs that are experienced in doing the test. You have to establish a reference range, and you have to correlate the different disease states. I have used a thromboelastogram, not TGA. We're actually looking at one of the Stago instruments called the Genesea. My colleague in research is using that for her research in trauma. So we hope to study that in clinical medicine to see, does that, well, number one, does it give you a diagnosis? And it might. And number two, does it affect your long-term management? I have to say that the Europeans have done a lot more studies. Dr. Hemker is doing a lot of studies, a lot of publications where he correlates that with, for instance, if you have somebody you're going to put on oral contraceptives, you might want to do a thrombin generation assay to see if they're at risk for getting a thrombosis in the future. I think the clinical application is yet fully to be determined.
So, inhibitors in a patient of hemophilia are always a cause of concern. Earlier, we didn't have much to do. Now we have almost like 3-4 treatment options, be it ITI, be it factor 7A prophylaxis, fever prophylaxis, or even emicizumab prophylaxis if resources are not a concern. How do you choose between these 4 options for a particular patient?
Yeah, good question. We usually go with convenience. We're so lucky that we have emicizumab. So for prophylaxis, I had a few patients who were on fever prophylaxis. We've switched them to emicizumab. Now, then you use recombinant 7A for breakthrough bleeds. That's been the approach. It's not an easily accepted intervention by patients who are, I'm not going to use the word elderly, but that's what they are in hemophilia world. They're so used to their own, and they're afraid of new drugs because there was a whole generation that died of HIV infection. But it's increasingly being accepted by the hemophilia community. So the bottom line, emicizumab is what we're using for prophylaxis and recombinant 7 for breakthrough bleed. Personally, I have not done ITI in the adult patients. It's usually the pediatricians that have done ITI. I think the questions that are emerging now are, if you have a pediatric patient with an inhibitor, they always get put on emicizumab. Should you be doing ITI in that group of patients?
Exactly, that's.
I think there's 2 ways to approach that, and I don't have solid knowledge or experience with that. But in theory, you could leave them alone, right? You could just emicizumab, go with Nova 7 for breakthrough bleeds, because they're going to be on emicizumab for the rest of their life anyway, right? Because they presumably have severe hemophilia, and you're going to give them emicizumab anyway. Why spend the money giving them high doses of factor VIII to get rid of an inhibitor? Now, the disadvantage of that approach is that if they need surgery in the future, it's always better to use factor VIII, right? Rather than going with empiric Novo 7, there's a 7-fact out there as well. So you can see the arguments for both sides of the situation. I don't know what the pediatricians are doing right now. Sometimes I say, I'm glad I'm not a pediatrician.
Dr. Raj Varian wants to know, what happens to APTT mixing study in contact factor deficiency?
Contact factor, so that's factor 12, high molecular weight kininogen or prekallikrein deficiency. The APTT mixing will correct right into the reference range.
Right. Another question from Dr. Raghunathan is, how do you approach a patient of isolated increased prothrombin time with new onset bruises?
Well, for the diagnostic workup, I'd still do the same mixing study factor assays. But I assume in this context, the APTT was normal, making factor 5 less likely. Depending on what you find on testing, most of the time it's a mild factor 7 deficiency. It shouldn't explain the bruising. So I would still look for other explanations for the bruising. Could it be acquired von Willebrand? Could it be ITP? All those sorts of things.
Right, sir. Dr. Ankita Sen, you have a question?
Yes, sir. I would like to ask regarding a child, acute leukemia in induction phase and L-asparaginase induced thrombosis. So I would like to ask you which would be your preferred anticoagulant, a low molecular weight heparin or one of the newer anticoagulant agents?
Good question. So the mechanism of L-asparagine-induced thrombosis is antithrombin, acquired antithrombin deficiency. So heparin may or may not be effective. So depending on how young the child is, in the acute induction phase, I'm not sure I'm very comfortable using DOAC because I presume the patient will need lumbar punctures. The patient may bleed because of severe thrombocytopenia. So I would still consider using unfractionated heparin, which you monitor. If you use low molecular weight heparin, I would still check anti-10As to make sure that they're therapeutic. But more importantly, I would replace the antithrombin. Because if you replace the deficient, intermediately molecule, heparin should be effective.
Thank you, sir.
So in our patients with the ALL who are getting L-asparaginase, we empirically replace them. Empirically, we don't even wait for thrombosis because then you're dealing with these consequences of DVT and how to manage the anticoagulants.
So you are empirically giving the patient unfractionated heparin? Okay,
No,
throughout
no, antithrombin.
Oh, antithrombin. Okay.
Concentrate.
Okay.
Yeah.
So like, how are you using? At what frequency are you giving the antithrombin?
Yeah.
Whenever LASP is indicated in the protocol?
We measure levels. So once you get a baseline level, and then during the L-asparaginase therapy, we measure levels once, maybe twice a week, and then we target. You don't have to target 100%, 120%. We just target 80%, 70% of antithrombin. It'll drift down, and then you check another level at some point. It's much more cost effective to do it that way than give an expensive concentrate just once or twice a week.
Okay, sir. Thank you so much.
The question from Dr. Sitaram. Pregnant woman, unprovoked DVT. Should you do the workup for prothrombotic disorders?
Well, the pregnancy is a provoking event. So the answer is no, I wouldn't do a thrombophilia workup. Yeah.
Right. So the other questions have been answered. Yeah, I think you have answered most of the questions lying in the question box. Anything over here? You unmute yourself.
Chandrakala, sir. Sir, regarding the PTS, actually, so do you advise any patients like a catheter-related thrombolysis or thrombolysis, any indication like a proximal DVT are involving the IVC? So any of patients will be advisable to go for thrombolysis over the anticoagulation, oral anticoagulation?
No, there's some pretty strict criteria on who should undergo thrombolytic therapy. And really, it's only life or limb threatening, like a phlegmasia or something like that. It's really controversial, isn't it? Systemic thrombolysis versus straightforward heparin or whatever and anticoagulation. I think the bleeding risk is very high in both the arms, but particularly in thrombolytic therapy arms. So hemodynamic compromise for a PE, quote unquote massive PE, and there's some definitions for that, or life and limb threatening phlegmasia are the only two indications our vascular doctors use.
Thank you, sir. Thank you, sir.
One question from the audience is, if there is a patient with inherited prothrombotic disorders, do you screen the family members who are asymptomatic?
Yeah, it's a really good question. A very common scenario. We counsel them. My own approach is I discourage screening. And there's a particular problem here in the US is that if you're labeled with a genetic disease, will you be subject to discrimination, life insurance, health insurance? I mean, the laws are such that health insurance discrimination is prohibited, but I don't think life insurance discrimination is prohibited. That automatically you're put into a high risk category. And so I discourage, but I give them the written material on to read about it, and I let the individual family members make the decision. Nobody has quite asked me, I want to be tested, so test me. And if they did, I would say, no, I'm not going to, because I don't think it's right. but you're welcome to go to see your primary care providers and have them test you. I feel strongly. So that's the bottom line answer. Now you might ask, okay, if it's a young woman, she might get pregnant and get a DVT. She might go on oral contraceptives and get a DVT. That's a whole different counseling, and I don't think there's only one right answer, but my bias is not to test.
Thank you. Dr. Sitaram wants to know, in which cases of thrombi do you investigate for PNH?
Really good question. So for sure, thrombosis within the splanchnic circulation, so mesenteric vein thrombosis, or anyone with thrombosis with thrombocytopenia, hemoglobinuria, or pancytopenia and thrombosis. So those are the few conditions. I don't test everybody because you'll be doing a lot of testing that's not necessary.
Another question is portal vein thrombosis. JAK2 mutation is present. Do you treat only with anticoagulation or also give JAK inhibitors?
Anticoagulation for sure, but it depends on the blood counts. So if there's thrombocytosis, we control the platelet count with hydrea. If there's erythrocytosis, we do phlebotomy and hydrea. JAK2 inhibitors, I think, are mainly for those that have symptomatic disease, constitutional symptoms, large spleen, but certainly not just for thrombosis.
Right. A patient of thalassemia intermedia has undergone splenectomy. After splenectomy, do you give them antiplatelet and anticoagulants to prevent thrombi?
Yeah, really good question. I don't have a lot of experience with that. In our practice, we don't have actually any thalassemias except perhaps for thalassemia minor. The mechanism of thrombosis in splenectomy and thalassemia is the ongoing hemolysis, and it's really the plasma hemoglobin that's causing the endothelial damage. So really, it's the nitric oxide mediated risk. I think at the very least, antiplatelet agents is reasonable, but you have to be careful about anticoagulants and the risk of bleeding. But in the end, I have to admit, I don't have a lot of experience with that.
One last question. Are you seeing patients of vaccine-induced, COVID-19 vaccine-induced thrombosis with thrombocytopenia?
In our practice, very few. I mean, literally, I haven't heard of any in our enterprise. So we have Mayo Clinic is a large enterprise, in 3 states and multiple states. We're monitoring with our electronic health record is sort of uniform across the enterprise. We haven't seen any cases ourselves, but the reason perhaps is because Mayo as an enterprise first went with the Pfizer vaccine, so the mRNA-based vaccines. The Johnson & Johnson and the AstraZeneca were actually not used in our system at all, and that's only because of availability. But as you know, there's plenty of literature looking at cases. It's an important question because compared to the number of doses dispensed of the Johnson & Johnson AstraZeneca, the number of VIT cases is so low. On the balance, vaccine is still advisable. That's a message you have to keep giving.
Sure. Thank you. Dr. Tejaswini has put a question in the chat box. You are here, you can ask directly.
Sir, when do we evaluate for vitamin K metabolism related enzyme deficiencies?
It's extremely rare. Number one, if you see one case in your lifetime, that's already a lot. So they usually present in the pediatric age group with bleeding, just like you would with severe hemophilia or severe. So in that situation, a newborn or a young patient presenting with bleeding, you're going to check a PT and APTT anyway, probably. And if both are prolonged, that would be the rare instance where you would look for those deficiencies.
Thank you so much, Dr. Rajiv Pruthi. You answered so many questions. We consumed a lot of time. I'm extremely grateful to you. For the official vote of thanks, we have Mr. Shailendra Kumar.
us. Just so much. We delight listening to all the answers and a wonderful discussion. On behalf of the whole team of Panacea, our Managing Director, Dr. Rajesh Jain, and President, Mr. Neeraj Joshi, I very sincerely thanks Dr. B Agarwal and entire team of Mumbai Hematology Group and Dr. Pruthi for a wonderful deliberation today. Sir, today we are the 4th largest company in biotechnology and the 12th company in oncology in Indian subcontinent. This thing has been possible because of the extensive support of you all. Today, on behalf of all my team members, I wish you all a very, very safe time because you all are actually fighting from the front. Thank you so much for saving the humanity. And I request you all to stay safe, stay healthy. Thank you so much, sir, once again for giving us this opportunity of being a part of Mumbai Hematology Group program. Thank you, sir. Good night to everyone.
Thank you. And thanks, Dr. Rajiv Pruthi again. Thank you very much.
Thank you, sir. Thank you. Thank you. Thank you.